Hi, I'm Dr. Neal Bhatia. I'm Director of Clinical Dermatology at Therapeutics Clinical Research in San Diego, California. So treating the field is just as important as treating what you see. And remember that, no matter how good a clinician we are, there's still an iceberg effect of every tumor. That we see probably 10% or 20% of the visible tumor, and everything else is still under the microscope or under the hood, if you will. And again, changing the concept of treating the entire field and not just what you see in front of you is really significant, not just for superficial basal cell, but for actinic damage as well, and for actinic keratoses, of course. So I think treating the entire zone of damage and making sure we get what's on the way as well as what we see, I think is very significant in terms of giving patients a long-term advantage in reducing their skin cancer risk. But photodynamic therapy in this way of thinking is probably the most effective chemoprevention agent we have, even though, again, we don't talk about FDA-approved chemoprevention strategies because there really aren't any, and we really don't have a lot of patients who want to take systemic retinoids anymore. When you talk to patients, they'll come in for what they see or what they feel, or they say something's not healing. Obviously, most things are biopsy proven. And talking to them about the subclinical risk is just as important as talking about what they see in front of them or what's under the microscope that's proven to them, because the risk is basically cumulative. You be giving rise to potentially more skin cancers or more actinic keratoses down the road. And again, you can use the example of termites in the house. You see one, there's 10 more. You could use the analogy of rats. You see one rat, you see 10. So whatever is coming is really the way of thinking about how you want to take care of what you see today. So I think in turn, if we're not treating in a way that's preventative or at least aggressive to the field of damage, I think we're not being complete in our approach of treating what we see in front of us. The fact that we have a non-surgical opportunity to treat, whereas we think about scarring, we think about chemoprevention, we think about all the different cosmetically sensitive areas. This is where photodynamic therapy really gives us an opportunity to, again, have a non-invasive treatment that, again, not only will help improve the photodamage and the actinic damage, as well as give a little bit of potential cosmetic benefit to the area. We also have good study data that shows that there's clearance of those areas and clearance of the tumor. So I think to have that in our hand to give, again, patients who might have surgical fatigue or bad cosmesis areas or cosmetic subunits where the tumors are, this is where, again, we have a good chance to treat them a little bit more conservatively, but yet also thoroughly. Well, I mean, in cosmetically sensitive areas, we think about face, the chest, even back of the hands, places that patients are going to be seen. And there really needs to be a very complete algorithm of what the patients are going to do to maybe pre-treat the areas, as well as treat after whatever the definitive treatment is for the tumors or AKs. Obviously, combinations of retinoids, for example, serums that will help restore the integrity of the skin, polypodium leukotomous extract for, again, photoprotection strategies. Obviously, sunscreen is a mainstay for these areas, but PDT especially has really good data with the reduction of not only the lesion count for actinic keratoses or the clearance of tumor, but also the improvement in the cosmetic subunits, the sallow skin, the wrinkling, the dyschromia, all of that gets improved with PDT. And photodynamic therapy, whether you use red light or blue light, has the same potential outcomes. Whereas with liquid nitrogen, you're definitely dealing with the risk of dyschromia. And if you're not using something topically to maintain the gains, I think again we're looking at not improving the cosmetic subunit, but also that higher risk of recurrence of whatever the primary lesion was.